All right, I think we'll get started. Thank you all for being here. It's a kickoff of our EPI seminar for the spring semester 2026. I know it's cold out there, but for some of us, I went to school in Iowa and lived in DC, so it's not that bad for me, but for others it might be. So there are a few who are on Zoom as well, so hope you are warm and safe wherever you are. So rest of you, thank you for coming again. So today we have Dr. Robert Blake Buchalter. I got that right. He's an assistant professor. He's brand new. He's the most recent faculty in our department. So we thought about doing it in Zoom today, but I thought he needs to be introduced in person. So it's good to have you here. So he got his bachelor's in mathematics and biology from University of Alabama. I'm assuming Tuscaloosa. Yeah. And then he got his MPH from UAB here in the School of Public Health. Then after that, he went to Oregon State University to get his PhD in epidemiology. He's done several postdocs, fellowship, one in Oregon Health and Science University, and then the other one in Case Comprehensive Cancer Center in Ohio. His expertise is in geospatial analysis. That's what he's going to be talking about. He is a recipient of the Impact Award here at UAB Hersing School of Medicine. I'm sure you mentioned that a little bit and describe what that Impact Award is. So with that, please join me in welcoming Dr. Buchalter, Assistant Professor here in the Department of Epidemiology.
Thank you very much. Happy to be here today. And sorry about the weather. So I on the next slide, I actually have my face showing so everyone online can see who I am. So today I'm going to be talking about geospatial analysis, geospatial methods mostly applied to chronic disease epidemiology. So I'm going to do kind of rapid fire through a bunch of projects, but I'm also going to introduce sort of what geospatial methods are, what geospatial epidemiology is. So first, just a brief background on me. So yeah, I'm the newest assistant professor in EPI here at UAB. So some of my previous roles, so most recently I was a postdoc at Cleveland Clinic in Cleveland, Ohio. I was also at the same time a postdoc at Case Comprehensive Cancer Center at Case Western Reserve University. So before that, I was in Oregon, so at Oregon State University and OHSU in Portland, in Corvallis. So I did my PhD there, and before that, I was actually here at UAB for a couple of years doing my EPI MPH. Before that, I was at UA in Tuscaloosa. So I'm going to jump right in. So what is geospatial epidemiology? So there's a lot of different ways to describe what it is. The way that I like to describe it is sort of follows what Elliott and Wartenberg said in 2004. So basically, it's sort of the mapping and sort of the analysis of geographic variations in disease. There's a bunch of different components there. I'm not going to list all of them, but putting into my own words, it's sort of describing and analyzing disease at the population scale and taking geography into account. So that includes mapping and geographic analysis. So there's a couple of examples on the bottom. I'm going to go into those a little bit more into depth later on. But basically, different types of cluster analyses, converting different types of values from one spatial unit to another, and also there are different types of modeling techniques as well, which is on the bottom right there. So getting into the historical components, sort of where were we and where are we now in terms of geospatial work in epidemiology? So it goes back to Tobler's first law of geography. Everything is related to everything else, but near things are more related than distant things. So I think that kind of rings true even into my work now. And there's really been a strong spatial component to epidemiology since it began as a scientific field. So I like to include this map. I think there's a lot of EPI presentations you're probably going to see that have this map, but it's John Snow's original mapping of his cholera investigation in London in 1854. So you can see sort of the stacked rectangles that are cases, and also the pumps to sort of see where the cholera cases were in comparison to the pumps in London. So this is spatial epidemiology, and it's one of the very first, or it is the first investigation. So, and modern spatial epi really relies on advancements in the last 20 or so years, and that is sort of signified by the release of ArcGIS from Esri in 1999, and it's sort of exploded since then. So then briefly, I'm also going to talk a little bit about a few more components of the background of spatial epi, and then I'll get into a bunch of the projects. So I think it's also important to introduce spatial data. So there's a couple of different categories. I won't go into this super in depth, but basically it comes in two categories: vector data and raster data. So vector data can be things like points, so geographic coordinates on a map, lines, for example, roads or rivers, and then polygons. So if you think about counties or census tracts or census blocks or block groups or whatever. So there's also raster data, and this is basically just images. So this can be things like, it can be discrete or continuous, so things like land cover, and so you can see where there's forest versus developed land versus whatever. And then there's continuous, where you think about, air pollution, satellite images, and a bunch of different types of air pollution data that you can look at. So getting into probably one of the main ways that most people think about what geospatial epidemiology might be, and that's basically just disease mapping. So there's a few different examples here. So, childhood obesity in New Mexico by block group, right? Or breast cancer cases and controls in Cape Cod, or heart disease mortality rates by county at the bottom there. And there's also, you can create heat maps like this too. So cancer incidence in Ohio, and I think that's actually pretty unique. Not a lot of cancer registries make maps like this, but I think that's a pretty cool way to do it. So that's just an example of different ways that you can use disease mapping. This is sort of the most basic geospatial epidemiology sort of method here. So to get into a few key considerations, and again, I'm not going to go super in depth here with this because I think it's maybe, it's a little bit outside of the range of what I'm trying to focus on here, but I want to introduce a few of these. So a couple of these considerations include scale. So thinking about the ways that the spatial data is actually set up. How granular do you want the data to be? So like, for example, block groups versus zip codes versus counties, and sometimes if you use different scales, it can show different patterns. And then also boundaries. So boundaries generally are not really made for analysis of epidemiologic data, right? It's usually administrative boundaries, economic boundaries, things like that. So I think that's really important to introduce too, because a lot of the analyses that I do are using administrative boundaries because that's where the data exists, right? But I think it's important to note that just because these are not ideal for epidemiologic analysis, and it's very important. So a couple of other components here, really just the last one, is spatial clustering. And this is something that is both a method and it's also something that you adjust for in your analyses. So in spatial modeling, this is kind of the entire goal, is to adjust for the clustering in the data. So, when you're using aerial unit data, like this map of Massachusetts here, there's almost always clustering in whatever you're looking at. So, you can identify that using various methods like Moran's eye. There's a bunch of different clustering methods. And it's also useful for looking at clustering patterns locally, so you can actually locally and globally look at what the patterns are. And basically the difference between those is you're just figuring out, is there clustering or is there not, and local is basically trying to figure out where that clustering is actually happening. And again, importantly, you can adjust for that, and I think that's the entire goal of spatial modeling. So I'm going to jump into some of the projects that I've worked on and sort of exemplify a lot of these components that I've explained. So first, I'm going to get into sort of an early onset colorectal cancer project. It's a cluster analysis project. So to introduce that, I think it's important to show the burden of colorectal cancer, because that's really what we're focusing on here. So colorectal cancer really still has a very high burden in the U.S. population, both among males and females. So it's the third highest in terms of new cases and also mortality. And however, it is getting better over time. And a lot of that is being driven by increasing screening rates. So the incidence rates for colorectal cancer are dropping very fast over time, and most of that is being driven by increased screening uptake. And also there is a smoking component, how smoking rates have been reduced over time. So both among men and women, incidence and mortality have been dropping for decades now. However, in young people, there's been a very strange pattern that's been sort of developing over the last 30 or so years, where both incidence and mortality in those under 50 years old has been strongly increasing. So basically we're trying to figure out why that's happening, and for me, where that's happening. So this was sort of an introductory project from a couple of years ago. So there really weren't any national small area studies of hotspots of early onset colorectal cancer incidence or mortality. So we started with mortality here because there was less data suppression, and it sort of, in the county level, sort of gave us that introductory look. So the objective here was to identify groups of counties that had higher and lower risk of early onset colorectal cancer and mortality. And this was sort of a way to show evidence that there may be certain states or regions where we should do more in-depth study. So the methods behind this, so this is a hot and cold spot study, like I was saying. So we basically stratified the data to different age categories, and then we used this circular spatial clustering technique, and you can see these figures here. Basically what this does is it sort of scans through the data with circles and figures out where there are hot spots and cold spots. And we set up these models that are adjusted for various prognostic indicators and risk factors for early onset colorectal cancer. And I'm going to skip this slide actually because it's hard to see, and it was the main result figure for this study, but I'm going to go in and zoom in so you can see these better. So you can see for under 50 years, this was adjusted. You can see a couple of hot spots. There's one really in all of the entire southeast. So this is early onset colorectal cancer mortality. Again, there's also one in sort of the Midwest Lake Erie region, sort of, and then there's a very large hot spot in the western United States in Texas. So then what we did, because we thought there may be differences when you get very granular with the age category. So this is under 50 overall. So we also wanted to split it into 35 to 49, and we also did under 35, which I'm going to show on the next slide. But the 35 to 49, you can see sort of a pretty strong southeastern pattern. Again, it splits into two hotspots there in the southeast, and you still see the Lake Erie hotspot up there as well, and then broad western cold spots still. But interestingly, when you break it into the under 35, you don't really see that southeastern hotspot anymore, and it sort of just centralizes sort of in the Midwest, so around the Great Lakes area. So there's two up there. So that was really one of the most interesting parts of the results of this study. And then I wanted to also make sure to show, because you want to be able to compare. So you can find the hot spots for young people, right? But you also want to be able to compare it to people that are 50 and older, and also have different stratified age categories as well for comparison's sake. And you can kind of see, again, there's a lot of southeastern hot spots. There's actually some in the in the Midwest, the Great Lakes region as well. But interestingly, you don't see that the southeastern hotspots disappear for any of those. They stick around. So that was the most important piece of this, I think, is that the ages under 35, the mortality hotspots sort of shift northward, and you don't see them in the southeast anymore. And the hotspots for 35 to 49 years, so a little bit older, but still in the early onset age category, those more closely resemble the southern hotspots that we saw for ages 50 and older. So that indicated to us that mortality in that under 35 group may have different drivers than the older age categories. So that sort of indicates as well that risk stratified screening beyond just age cutoffs, because they did recently move the screening age for colorectal cancer from 50 years to 45. So the idea is that there may be other types of risk stratified screening beyond just age cutoffs to look at. So that was sort of the goal here, is maybe think about geographic targeting of screening as well. So we're just starting with that kind of stuff, and we're trying to move down that road now. So I'm going to move on into the next project. So the next project is still related to colorectal cancer, but it's more heavily about screening. And it's specifically looking at Hispanic or Latino populations and sort of the heterogeneity among them. So I'm going to shift gears a little bit. So first, I think it's useful to introduce that screening rates by race and ethnicity, there's a lot of heterogeneity over time. They are increasing over time. So among all the race and ethnicity groups shown here, so non-Hispanic white, non-Hispanic black, Asian, Hispanic, or Latino, they are increasing. But the levels, none of them are like spiking and reaching the same level as non-Hispanic white. So I think that's important to show. And there's also geographic heterogeneity, looking at late-stage cancers, which is sort of the way to look at how well screening uptake is working, right, to compare across geographic areas. So you can sort of see, so this is for Hispanic or Latino populations. You can see there's quite a bit of geographic variation here in late-stage incidence. So that sort of is the reason that we wanted to do this project, which I'm going to get into more of the details here shortly. So I think it's also important to show, because the idea here was to look at the different types of Hispanic or Latino subpopulations. So Mexican, Puerto Rican, Cuban, Dominican, Central American, and sort of see how the screening looks different from a geographic perspective for each of those groups. So you can see the leading Hispanic group by county. So, there is quite a bit of heterogeneity, but the Mexican population dominates a lot of the counties in the United States for the leading Hispanic group. But still, it's very important to show this before we get into the reasons and the actual methods for doing this. So also, when you look at cancer mortality, there's also a lot of heterogeneity when you look at different types of Hispanic or Latino subpopulations. So you can see, for example, that on both of these, for both men and women, that the Central and South American, and I think I'm reading that right, yeah. The Central and South American is a little bit lower, and also the Dominican is a little bit lower for mortality than other populations. But really the point here is just to show that these groups it's not a monolith. The Hispanic or Latino population is not one single population. It's a lot of heterogeneity. So that was the point of doing this study that I'm about to introduce. So we were trying to basically identify colorectal cancer screening disparities among different Hispanic or Latino component groups. So we wanted to examine the relationships between Hispanic or Latino population percentages and colorectal cancer screening rates. So here we use CDC Places data. So this is tract level screening estimates. And then we use the covariates. We use the various component group populations: Mexican, Puerto Rican, Dominican, Central and South American, Cuban. And we also use non-Hispanic white, non-Hispanic Black, and also health insurance percentage, in addition to area deprivation index. So I'm not going to get too deep into the methods here, but basically we did a compositional data analysis for the race and ethnicity groups. Then we used a geographically weighted regression and a cluster identifier. And again, you don't need to look at this too hard because I'm gonna zoom in, but this was the main figure here. So basically what we did is we took the geographically weighted regression local coefficients. We identified clusters after using that method, and then we were able to basically identify areas where interventions might make sense, right? So where you could roll out screening interventions in local areas. So, and also have included an interpretation here just because I think it's a little bit easier when you actually see it on the slide versus me saying it and like having like a paragraph for saying what this means. But basically the idea here is these are areas identified where you could increasing the screening uptake may specifically benefit the Mexican population in these areas. So we did this for all of the different component groups. So you can see from a spatial pattern perspective, you can see tons of census tracts identified in Texas throughout sort of the Southwest, but there's actually quite a few in other areas. You just can't see them that well, even in, Kentucky, Ohio, Illinois, North Carolina. So there is quite a bit of heterogeneity from a geography perspective here. So getting into the next one, so the Puerto Rican population, again, this is the interpretation here is these are areas where screening uptake interventions may specifically benefit the Puerto Rican population. So you can see sort of in New York City, even in Florida, there's some places in California, Northern California. So it is still hard to see this. So another thing that I like to do is create interactive maps. But I can't show it here. It's going to completely mess up my presentation. But we have this in an interactive map as well because the static maps, it's really hard to see what is going on because there's a lot of very small patterns that you can't see on a static map like this. So using interactive maps is also something I like to do to be able to make it easier for people to actually zoom into their local areas. But I'm not going to be able to do that today because I'm going to mess this presentation up if I do that. I'm going to have to close everything. So next is Cubans. So these are areas where, again, where you could specifically target interventions specifically that would benefit the Cuban population. So I'm not going to go too deeply into this, but mostly the bunch of census tracts in Florida, throughout the Midwest, New York City, etc. So the conclusions here were basically we identified where priority areas are for these different Hispanic Latino populations where we could target funding, policy, different types of intervention programs. I created that open source map that can be used by interested parties, the general public, policymakers, etc., to zoom in and really see what the burden looks like. And then sort of the next steps from there could be using the same sort of methods to look at other populations. So for example, the Asian population, there's a lot of heterogeneity in the different groups that make up the Asian population in the United States. So you could do the same sort of analysis for that group as well. So that's sort of the next step there. And again, I'm gonna change directions here a little bit because I want to get into the spatial access to care work that I do, which has a lot of chronic disease components in it as well. So I'm going to step into that really quickly. So again, changing direction. So when you talk about access to care, there's a lot of different components that go into what makes access to care. And really what spatial access to care is focusing just on two of these. So I like to preempt this by saying I'm not like solving access to care. I am just providing some more inputs into what access to care, how to measure that from a quantitative perspective. So spatial access to care focuses on accessibility and availability. And that's the only components that it focuses on. It does not focus on affordability, accommodation, or acceptability. And I like these 5 A's from, I think Georgia Tech came up with these. But I really like these because I think it's easy to remember and easy to know sort of what I'm trying to target with the analyses that I do in this space. So the first one that I'm going to talk about is a project looking at access to neurologists in Appalachia, focusing specifically on Appalachia because you can look at the area deprivation. So this is the sort of all the states that have Appalachian components in them, and sort of in the middle there you can see sort of the black outline is what the U.S. government actually classifies as Appalachia. And it's actually relatively granular. I believe that it's census tract locations that have been cut out to show what Appalachia actually is. But you can see very high deprivation in the area, socioeconomic deprivation, very, very rural. So it kind of made sense to do a project focusing on access to care in this region because there are very stark health disparities, right? So I think this is a very easy way to show that, which is the years of potential life loss in the Appalachian region over time. So you can see basically how much worse it's getting over time. So it made sense specifically to focus on this region, looking at access to care. It also is it's also considered sort of part of the stroke belt in this area. So that was sort of the reason that we wanted to focus on neurological care, because there is a very severe stroke burden in this area and very high stroke mortality rates in that area in Appalachia, and you can see specifically in Alabama as well, because a lot of people don't know this, but Alabama is included in Appalachia, and I think that that's sort of forgotten. So Alabama is included in this analysis as well. It's not just sort of northern Appalachia. So getting into more detail of sort of what we did here. So we wanted to compare spatial access to neurologists between Appalachian and non-Appalachian census tracts in the states that have Appalachian census tracts. So I think that makes sense. And then the methods that we use in the data. So this is a cross-sectional study. We use this really great resource from CMS, their Care Compare physician location data. So it actually is all physicians that practiced and billed Medicare or Medicaid within the last year. So it's technically active physicians as far as we know. It's the best resource you can use to get locations of physicians and providers. So sort of the framework here is we computed the floating catchment area measures, which I'm going to get into in the next slide. Then we stratified the access to care ratios by state, area deprivation, and rural-urban commuting area codes. And then using those stratified results, we actually were able to produce intervention priority areas, sort of like we did in the previous study that I talked about, where you can figure out, what are the areas that should be prioritized for funding, programs, and maybe policy changes. So a little bit more about the method that we're using for this. So this is the floating catchment area method. I'm not going to go too deeply into this. Really, really basic. You pretty much create a distance matrix between areas. So how long does it take to get from X census tract to Y census tract? And then you put that into the algorithm as a travel time. You have the number of providers in a given census tract. You have the tract level populations, how many people live there, and that basically it spits out your weighted provider to population ratio, and then you convert that into a further ratio to basically make it easier to identify disparities between regions. So this was the main figure from this study, well, one of the main figures from this study, and basically I'm showing the different ways that you can operationalize this analysis, because there's different ways of doing this floating catchment area analysis. So you can set up these catchments in different ways. So you can have basically a catchment where you're using the entire 60 miles. So you're basically assuming that everyone in that 60-mile catchment has the exact same access to care. But that's panel A. So you can see how there's much larger circles there around academic medical centers mostly. And in panel B, there is a much more severe restriction, basically trying to account for the fact that patients are not likely to use that entire 60-mile or 60-minute catchment, right? They're more likely to go to providers that are nearer to them. So that's what that helps account for. So panels B and C help to restrict the patient flows basically to areas that are much closer to where patients actually live. So these were the main figures, and we ended up using panel B as our primary, where we calculated these intervention areas in the next. But some of the patterns here, as you can sort of see when you're comparing the Appalachian area in the center to the non-Appalachian areas surrounding it, you can see that generally there's worse access to neurologists, just based from a visual pattern perspective, and our statistical results show that too. So these were the intervention areas that we identified. These are pretty large, so you could restrict these further, but this is what the spatial analysis showed us, that these are areas where it may be worth intervening to specifically increase the number of neurologists in these areas. So the conclusions from this, so we found that Appalachian tracts in comparison to non-Appalachian tracts had spatial access neurologist ratios that were between 25% and 35% lower than non-Appalachian tracts. So very, very large differences there. Urban and rural were the most important drivers of spatial access to neurologists in comparison to socioeconomic status. Also, this was not fully a rural phenomenon, however. So there are some Appalachian urban areas like Knoxville, Greenville, Charleston, West Virginia, that had poorer spatial access to neurologists than non-Appalachian urban areas in those Appalachian states. So the idea here is maybe you could use, incentive programs to keep providers in these areas, or other types of policies to attract physicians and providers to rural Appalachia to assist with some of those gaps in care. So moving on to the next one. So we're still staying in the spatial access realm. The idea is we started with Appalachia. We wanted to expand this. We wanted to go national with this sort of analysis. This is actually a brand new study that we just finished, that was just published. And we wanted to expand this. We wanted to look at tons of different types of providers instead of just neurologists. So we wanted to do this for the entire U.S. So the idea here, we wanted to also expand the method that we're using, because we were focused only on car travel. And I think we thought that, maybe introducing transit, walking, it might make sense from the perspective that patients in different areas are likely to use different travel modalities. So the gap here is there was a lack of studies that used different types of travel modes, and there's also a lack of studies that looked at it over time. So we wanted to do this for a ton of different types of healthcare providers. So we used these realistic travel times that we computed, and also use multiple modes of travel integrated into these metrics. So again, we use that CMS data set to quantify access to care for a bunch of different types of providers, 56 different classifications of providers, quarterly from 2016 to 2020. Then we also created those metrics for both tracts and census block groups, and we created this composite index, and I'll go into this a little bit. So I'm going to go through this very quickly. You don't need to be too scared by all the Greek letters down there. I'm just going to really go quickly through this. So we used census tract and block group population, the population centers, and we fed that into a routing algorithm using both car, transit, and walking travel matrices. So computing those is very complicated for the entire United States to try to figure out, how long does it take to walk from this census tract to that census tract, because you need that to be able to compute this. Not that anyone's actually doing that, but it's important to be able to do that for the entire United States. So that was a complicated process to make those. And then we use this two-step floating catchment area method using, and this is step weighted, which I didn't say previously, which basically means, if it's 0 to 9 minutes, that's the highest weight. 10 to 19 minutes, that's sort of in the middle, and then 20 to 30 is the lowest rate or lowest weight. Then we computed this proportional weighted average between those, and we weighted that based on how people actually travel in a given census tract. So there's ACS from the Census Bureau, they actually release the number of people that use X versus Y transit modality or walking modality or whatever to see how people are actually traveling to work. So we use that as a proxy to weight these to create these metrics. So getting to the actual results here. So this is for Washington, D.C. Because Washington, D.C. was a very interesting one to create these for. This is specifically for primary care in 2016. And I think the really striking panels to look at here is A versus B. So A is the composite, where you take into account all the different transit modalities that people are using, right, versus just car. So if you look only at car in panel B, the access to care looks pretty bad throughout all of the Washington, D.C. sort of metro area. But if you look more in depth, you can see in panel A, when you introduce transit and walking, the access to primary care actually increases quite a bit. So that's what was really one of the interesting results of this. We also included, how many people are using cars to commute. So that's panel C in area deprivation, just for comparison. So that was one of the major things, is you can see panel A versus panel B. So I'm going to show a bunch of different areas though first, and then I'm going to show Washington, D.C. first, then I'm going to get into a bunch of different areas. So I think the interesting thing here too is we did not just do primary care. So this is all specialty care providers, and again you can see sort of the comparison. So panel A over there versus panel B, you can see how in panel B, when you're only looking at car-specific spatial access, the access to care doesn't look that great. But when you actually see that people are using other modalities besides just car, they're using transit and they're walking, you can see that it is much increased in panel A versus panel B. So that's what we were trying to show with this study. So I think also the component here is we did not just do a cross-sectional study. It was temporal as well. We want to show that temporality in different areas. So that's one of the interesting things here. So this is specifically for cancer care. And you can see in the Cleveland metro area, sort of access to cancer care exploded between 2016 and 2019. And you'll see that in a couple of different areas here, because I'm going to show Houston and also San Francisco, sort of compare and contrast those. So you can see how much cancer care increased over time, just in a few years in the Cleveland area. Same story in Houston. So for cancer care between 2016 and 2019, greatly increased, sort of centralized in that central Houston area. Actually kind of reduced a little bit in the northern component, or the northern area of Houston, sort of the suburbs up there. And then very interestingly, however, in San Francisco, so this is the sort of the San Francisco peninsula right there, I think you can call it that. It's this. You can see how cancer care actually contracted in San Francisco between 2016 and 2019, which was very interesting to me when you compare the different areas. It's important to note, it's not just the number of providers; it's also the number of people that live there, right? So that's how this works when you're computing these type of metrics. So there could be population increases, physicians moving to Oakland or moving somewhere else that can cause these changes. But it's important to note the the actual scale of the numbers that we're working with is relatively small, right? So the visual is maybe a little more striking than the actual on-the-ground differences for the average everyday person that's seeking cancer care. So the findings from this, this was a really exciting study to do. It was just published recently because we were able to produce these access to care composite metrics for the entire United States for 56 different provider specialties, and we did that quarterly. So if people want to use this data, it's out there, it's available to use from 2016 to 2020. We're trying to make more of these going forward, so it's more useful. And we found that the car access alone underestimated access in areas that have higher utilization of other types of forms of travel, like transit or walking. We also found that access to primary care was lower than specialty care access in 2016, and this did not improve by 2019. So also the differences, there were rural and urban differences, so micropolitan, small town, and rural areas had significantly poor access both cross-sectionally in 2016 and also over time in comparison to metro areas for both primary and specialty care. But there were no clear trends for socioeconomic status for ADI, so we didn't really see anything there. So that sort of concludes the spatial access component. So I'm going to do one more, and this again changes gears pretty significantly because I think it's important to also show that there is some environmental, because I think when people think about geospatial epidemiology, it's like, okay, when are you going to start talking about air pollution and all of the environmental components? So there is some of that as well. That's not my primary focus of a lot of my work. So to get into a little bit of that, just for people that were expecting more of that, this is some background into chronic kidney disease and some of I've done a couple of studies in this, and this is more of an environmental component. So to get into it a little bit, just some of the background. So, and again, we're changing topics very suddenly here, but the end-stage renal disease, the burden has been rising quite a bit in the United States. So the patterns across areas there's very severe differences between different areas. And you can see sort of some of the previous work that's been done there looking at end-stage renal disease prevalence and the clustering in areas. So very, very southeastern pattern there for chronic kidney disease burden. So diabetes and hypertension are major contributors to both chronic kidney disease and eventual progression to end-stage renal disease. So there's been some work looking at air pollution and other environmental indicators that might be important here. But many of these environmental studies that have been done are related to studying pesticides in agriculture, different occupational exposures, so it's mostly restricted to that. But using associative methods, so using spatial modeling for looking at relationships between environmental exposures and chronic kidney disease is relatively rare in the literature. So this was a study sort of that we did that was more, instead of looking at individual exposures, we used this environmental quality index. So for this study, we looked at chronic kidney disease and the environmental quality index. So we got chronic kidney disease prevalence among Medicare beneficiaries from the CDC's kidney disease surveillance system. And that comes from the Medicare 5% random sample. So we adjusted in this analysis for diabetes and hypertension. And our predictor of interest here was that EQI from the EPA. So this is sort of a metric looking at the cumulative sort of exposures, both air, water, land, sociodemographic components, and then from there we performed these different types of spatial regressions, looking at geographically weighted regression, spatial lag models, spatial error models, and I won't get too deep into what those are, but basically the idea here was not just to look at the relationship between this environmental quality index and chronic kidney disease. It also was to show the differences between these types of models, right, and how they compare to traditional statistical models. So that was the goal here. So I'm going to show this these modeling results, and you don't have to look at this too closely. But basically, what we found here is that these spatial models just perform better than the base statistical models. So that was the goal here. So I highlighted in red, and if you look across, you can see how the point estimates change across, and that just has to do with how the spatial models just fit better. So you're basically removing some of that spatial noise to try to find, more likely to find the true relationship between whatever exposure you're interested in, whatever outcome. And you can see that in the maps as well. So what these models are doing is they're removing clustering. So when you have clustering in the residuals of your model, basically that violates the assumptions of the model that you're working with, because you're basically figuring out that the observations are not independent. So you're violating the independence assumption. So what these models do is help remove that. So what this is showing is basically panel C has the spatial error model, which is a type of spatial model, and it has the least amount of clustering. So it shows why that model fits the best among all of them. So this study was sort of showing the utility of using spatial modeling, specifically as it relates to kidney disease, eventually kidney transplantation too, for different ideas for what spatial models that folks in that realm can use to try to basically improve the model fits and try to figure out, what are the actual relationships between these environmental exposures and chronic kidney disease. So the conclusions here, really we found a significant positive relationship between worsening environmental quality, and that's a cumulative measure again, and chronic kidney disease after we controlled for diabetes and hypertension prevalence. And we found that most of the spatial models reduced the clustering in those model residuals. So that showed that the spatial models fit better, which is what we were trying to show, and that's what we were really interested in this study. And there's also some evidence of geographically differing relationships between environmental quality and chronic kidney disease. That wasn't really a focus of that because we used this geographically weighted regression, which basically shows how do the local coefficients shift in different areas. So we also found that was not the focus. And sort of moving on from there, we wanted to look at eventually the contributions of the individual pollutants, because like when you're using an index like this, right, you're not able to figure out what is actually contributing more or less to chronic kidney disease. So this was sort of a starting point, because I personally, for using indices like this, I don't think it's that useful for actually targeting interventions, right? Which is what the goal a lot of my work is local area interventions. So I know this was a lot of different projects because I wanted to show sort of the breadth of different ways that you can use geospatial modeling, geospatial analysis. But sort of the summary here is that these methods are useful in epidemiology, and I showed that initial slide with just disease mapping. It's a lot more useful beyond just creating a map, and that's where you stop. And specifically, spatial modeling is particularly powerful because you can separate the spatial noise from the signals that you're getting from your data. Because I think a lot of when you're working with county level data, census tract level data, a lot of the relationships that you end up finding between exposures and outcomes, a lot of it is just spatial noise where, like I was saying with Tobler's first law of geography, all these areas are all related to each other, right? There's natural clustering in both exposures and outcomes, and you have to remove that spatial component or try to account for it, or the relationships you find may just be showing that spatial noise. And also another focus of a lot of this work that I presented today is looking at those cluster analyses that can help or the priority areas that were identified that can help clinicians, implementation scientists and policymakers target interventions and funding and policies in areas of the highest need. So finally, I want to acknowledge a lot of my collaborators on a ton of these different studies, and I want to thank the organizers for having me here today. I was really excited to talk about my work and try to increase the interest in spatial epidemiology and spatial work in general, and I'm happy to take any questions.
Blake, are you teaching a course in spatial epidemiology, or do you plan to?
Not yet. I'd like to. I think it'd be fun. I'd be happy to.
I actually have two questions.
Okay.
First, I'm very interested in the study you just showed that published last year, last one.
Yeah.
And especially the trends between 2016 and 2019, I think that's amazing. But I also wonder, have you ever thought? I know you mentioned about San Francisco, which is decreasing to the successful care ratios and but also for the cities that you show Cleveland or Houston that have a rapid increase over 3 years, which to me is kind of I want to know what's your thought on that, because I can imagine the public transit or whatever the travel time from one place to another won't change that much in 3 years. And I know Houston, so I know that is a positive population growth. So it's not the population is reducing. So is that all of a sudden there are so many specialists most useful?
So there's a lot of variables to take into account here. So I know the Cleveland area because I trained there, and I know how rapidly their hospital system is expanding, and that's attracting a lot of physicians. So it may be the same with MD Anderson, where they're attracting a ton more physicians because it's expanding just very rapidly. So that would be my personal opinion. I don't know that to be the case for sure. Basically, I think the idea is that maybe that the number of physicians is matching the population growth, and it wasn't the same in San Francisco. And I don't know what again, this is this was kind of a long time ago now for San Francisco from 2016 to 2019. So I don't know if the population is still growing or what the case. Did you have a second question too?
Yeah, but no, it's kind of related. Do you happen to see, for example, 3 years later, 2022, or 3 years earlier,
Yeah.
to see if that trends hold over time?
Or
For example, if you compare 2019 to 2022, or compare 2016 to 2013, is there still rapid increase in 3 years or something like that?
So we only did 2016 to 2020 here because this data is unbelievable. It took us forever just to get those done. So we're trying to expand. So the physician file that we're using only goes back to I think 2015. So we only in 2015 getting that data, you got to email CMS directly to forget so 2016 really is the starting year for this. And then they release this monthly now. So the idea is we don't have 2013, but we're trying to expand to. So I can't tell you, but that's the next step.
So a question about that CMS physician file. So I know I looked at it at one point, and I think they list every address, every physician address combination.
Yep.
So could you be seeing that people as say maybe expand and takes over other, that somebody's there half a day a week,
That's definitely possible because there's no information about how long physicians work at a given clinic versus hospital. So we have to include all of them. So because there's no information about that, and we can't call each doctor individually, hey, how many days do you spend at this clinic versus that clinic? So that is an issue. That's a limitation with this.
So you're assuming they are full-time in all of those places?
Yeah, we're assuming that they're using all of those locations equally. We have to. It's the only way. This is the best one, and we don't want to pay. There's ways to pay to get. They call them master file to get locations for all of these. But really, this free data set is the best one by far, because you're actually getting active physicians that have billed Medicare and Medicaid within the last year. So that is a limitation, though. That's just part of it.
Oh, that's really interesting when you were talking about, primary care access going down from 2016 to 2020.
Yep.
So prior to that, during the Obama administration, when they passed a bill and basically required all providers to adopt an electronic health record,
Right.
which drove many physicians to retirement, becoming a hospitalist, because we didn't need hospitalists before we had computers. You have to have a hospitalist to do all the computer work that the specialists don't want to do. And a lot of people left like primary care specialties because it's expensive to have an EHR. You have to do a lot of work in them, and you don't get paid enough to have somebody to go around and do that stuff for you like the orthopedic surgeons have and people like that. So that caused a huge disruption to medical practice. So that's just something
That we did not mention that in our discussion, but maybe
Yeah.
maybe we should have.
Yeah. Right. Well, I wasn't practicing medicine then, thank God, but my husband was, and so I heard all of the cursing and various things that were happening, people learning how to, make Epic do what it
Right.
used to be able to just write a sentence and do.
I'm curious, you mentioned about the clustering analysis in the beginning of the couple of projects.
Yeah.
So, I'm wondering if you have thought about how to do uncertainty quantification, because there are several methods that can provide different clustering results. So what's the
And I've kind of transitioned over the span of my career. A lot of this, and this is from 3 or 4 years ago now. A lot of this is frequentist, so it's a lot of frequentist statistical. I started slowly morphing into using Bayesian because I think it's just better for cluster analysis, and it helps with there's going to be uncertainty, and I think a lot of this is very important too, because I'm identifying individual neighborhoods, and it could lead to significant, not saying that I'm important or something, but it could lead to significant investment in those areas. And if you choose the wrong area, and they're just wasting money throwing it in there, so I think that's a very important point. Is like how uncertain are we? How certain are we that this area is a place where you should target investment? So that's why I've started to shift, and instead of using those areas where it's like, okay, the p-value is less than 0.05, so this is an area you got to target. I think it's much better to do the Bayesian component. So yes, you're 100% right, and we're moving that direction.
welcome to the club?
Yeah, I appreciate it.
Yeah, and I'm also wondering any thoughts about in the border region of the clusters. Obviously, it's harder to model because there are
Yes.
the data is much more sparse around there. So
Yes.
So anything that you have.
Yeah, so that's actually why spatial methods are very powerful, because you can sort of create local shrinkage and you can borrow the strength of surrounding areas. So if you have a population center or a population, say we're working with counties, you have a very rural county versus county that has a higher population, you can try to basically shrink it to a local mean, so you have more smoothing instead of just very stark differences. Although, that still can be important, right? But especially in counties may not be the best example. When you're working with small areas, that's when it's most useful. So that's where I think actually spatial analysis becomes very it has strong utility in that perspective when you have sparsity like that. Yeah.
Enjoyed your presentation. Geospatial, I think I understand. I also think, that was relative. Access, I also think is money, and there's a money issue. And, that other thing. The third thing I think of is education or lack of same, which I think is beyond the studies you do. That is, the screening building might be right down the street, but I don't understand screening, or I think I'm not going to get that disease.
Yeah.
Is this study kind of in concert or along with the physical limitations of geography, and I don't have much money?
Well, I think that's why I introduced the different components of access to care. And like I had those 5 categories because I think I need to be very direct that we're only targeting a couple of those. And I think patient navigation, like you were saying, so they understand, patient education and navigation to understand where to get screened. I mean, that's a critical component, and health insurance, all those things. We were not trying to measure those things because I don't think. I mean, there is a spatial component in some ways. Because there's a spatial component, in my opinion, to almost every type of, at least aerial type of data. When you're looking, for example, at health insurance coverage rates over neighborhoods or whatever, there's obviously a geographic pattern there. But I mean, I think we're pretty explicit. I wasn't trying to do anything with those because I think it's it's kind of outside of this realm a little bit.
I mean, would you call that access or something else? Like the lack of education or understanding?
I mean, it is an access issue. But, I'm not sure it's a spatial access issue. Yeah.
All right, I think in the interest of time, we have to wrap it up. Please join me in thanking Dr. Buchalter.
Thank you.